A very good afternoon. At the outset, I would like to thank Vipul sir for inviting me here. So after such enriching mechanistic talks, I'll give your brains a break and I'll take you more through a visual perspective that how to approach a case of connective tissue disease. So when we talk about the connective tissue diseases, it includes SLE, Sjogren's disease, systemic sclerosis, inflammatory myositis, undifferentiated connective tissue disease, and mixed connective tissue disease. So when should we actually suspect connective tissue disease? If somebody has small joint predominant arthritis which is symmetric, if one has photosensitive rash which includes malar rash and other photosensitive rashes, if somebody has persistent oral or ocular dryness, Raynaud's phenomena occurring well into adulthood with no family history, skin thickening over the fingers in particular, puffy or swollen fingers, if somebody has subacute proximal muscle weakness, particularly in middle-aged females, or if there is a non-UIP pattern of interstitial lung disease. So these are the people where we should consider connective tissue diseases strongly. Now I'll take you through each one of them one by one. When should systemic lupus erythematosus be considered? If one has malar rash and there is a classical nasolabial sparing because that area is said to be photoprotected area. And if there is a history of photosensitivity, if there is painless ulcers, particularly occurring over the hard palate, if there is a alopecia, serositis, which includes pleural pericardial effusion or ascites, if there is small joint predominant symmetric arthritis, involving particularly the small joints of hands with early morning stiffness, if there is a cytopenias or fever of unknown origin. These rashes, these malar rashes can at times be too florid. If you look at the second image, there is a classical sparing of nasolabial fold, but if they are too florid, they can at times do not respect that nasolabial sparing, as you can see in the first image. Then they can be distributed over the extensor aspect of forearms, over the nape of the neck, shoulder region, upper back. So these are called as subacute cutaneous lupus rash. So they can be of papillosquamous variant or annular polycyclic variant. And at times they can be very disfiguring, as you can see in the first image, that is a DLE rash. There is a central atrophy, scarring, telangiectasias with hyperpigmented erythematous rim, and they can cause permanent scarring alopecia, mostly located over the scalp and the neck region and the face, but at times they can involve the hands as well. And chilblain lupus, generally if we see a patient who is working at high altitudes, in extreme winters, they can have chilblain lesions, but if one is developing it in Punjab or in warm weather, we should always suspect SLE. So these are tender erythematous violaceous papules or plaques which are on the acral surfaces. They are associated with desquamation, they are associated with itching. So if one is developing it in warm weather, or for that matter, even in winters in Punjab, I would strongly suspect lupus. Then at times the hands can have such kind of mulberry appearance. So this is as a result of palmar vasculitis, which is causing cutaneous ulceration and necrosis. And lupus profundus. So lupus profundus is basically a DLE rash, and if you can see that there are some sunken areas here. So these sunken areas are because of the involvement of the underlying subcutaneous fat. So inflammation of subcutaneous fat is called as paniculitis, and if there is an overlying DLE rash, so this is called as lupus profundus. So these are the different kind of cutaneous rashes which we see in patient of SLE. And this is the hard palate ulcer I was talking about. So this is classically painless ulcer. It looks very formidable, but it is painless. Patient only complains of pain when he tends to swallow something, when he tends to take meals. Otherwise, it doesn't cause pain. So this is the classical site of oral ulcer in lupus patients. Then this is Jacquard's arthropathy. So if you look at the first image, so there is very deforming arthritis. So patient has swan neck kind of deformities. But the moment you ask this patient to keep their hands flat on a surface, these deformities tend to disappear. So such deformities which are reversible is called as Jacquard's arthropathy, and it is very much seen in CTDs, not only in SLE but other connective tissue diseases as well. Now moving on to this next connective tissue disease, which is the Sjogren's disease. So oral or ocular dryness. I'm sure all of us had oral or ocular dryness at some point of time in life, but if it is persistent, if it is occurring almost daily for at least 3 months, then we should think of Sjogren's disease. Atypical caries. So caries, I'm sure many of us do have dental caries, but if somebody is developing caries involving the frontal incisors, so that is a very pertinent feature of Sjogren's disease. Parotidomegaly, as you can see in this image, that this female has bilateral parotid enlargement, which is again classical of Sjogren's disease. Again, small joint predominant symmetric arthritis, Jacquard's arthropathy, which I have told you. Hypokalemic paralysis. It's a very close differential of Guillain-Barré syndrome. A patient suddenly wakes up in the morning as he's quadriplegic. You check potassium, it's very low. And in that patient, on evaluation, if you find the cause to be distal renal tubular acidosis, then one of the leading causes of distal renal tubular acidosis is Sjogren's disease. Then ILD, particularly if there is a NSIP or LIP pattern of ILD, then Sjogren's disease must be considered. Now this is keratoconjunctivitis sicca. In first image, there is a fluorescent staining of the cornea, and in the second image, there is a lysamine green staining of the conjunctiva. So you can see because of the dryness, there is a multiple epithelial defects which are highlighted as fluorescent staining dots, and similarly over the conjunctiva highlighted by the lysamine green stain. And this is the Schirmer's test. It is said to be positive if it is less than equal to 5 mm in 5 minutes. And these patients, because of the salivary hypofunction, these can have hyperlobulated fissured tongue. And at times they can have palpable purpura. Particularly these patient tends to complain that after prolonged standing they used to develop such purpura over the lower extremities. So this dependent palpable purpura, which is nothing but cutaneous signature of leukocytoclastic vasculitis, is again a feature of Sjogren's disease. And they can have annular polycyclic rash just like systemic lupus erythematosus. And this is what I was talking about. So many patients, they will never, some patients even don't complain of ocular dryness, but the moment you see such kind of teeth, you should always suspect Sjogren's disease. So if caries are involving the frontal incisors, it's a very pertinent feature of Sjogren's disease. Then lymphocytic interstitial pneumonia. This pattern of ILD is very specific of Sjogren's disease. There are very few diseases in which this pattern of ILD is seen. One of them is Sjogren's disease, another is HIV, third is severe combined immunodeficiency. So you can see there are multiple thin-walled cysts involving bilateral lung parenchyma. So this is very classical for Sjogren's disease. Now moving on to the next connective tissue disease, which is systemic sclerosis. So Raynaud's phenomena is universally seen in systemic sclerosis. You should always suspect systemic sclerosis in a patient of Raynaud's phenomena. Now Raynaud's can again be primary or secondary. So when should you think that it is secondary, not primary? Many patients, particularly who occurs in high altitude, who lives in Himachal or Jammu and Kashmir, they do have this bluish discoloration of fingers. But when should you start suspecting that it is a connective tissue disease? So primary Raynaud's, which occur at high altitude, which is a normal thing, usually occur in less than 20 years of age, and usually there is a positive family history. So if there is no family history, if somebody is developing beyond 20 years of age, or if there is involvement of the thumb, because generally in primary Raynaud's, thumb is spared. So if there is involvement of the thumb, or if somebody is developing digital tip ulceration, then you should start thinking secondary Raynaud's, and you must send ANA, because these patients can very well have this connective tissue diseases. Then Raynaud's phenomena, then if it is severe enough, then it can cause digital pit ulcers or scar. So Raynaud's phenomena by and large can be seen in all the connective tissue diseases, but if it is severe enough to cause digital pit ulceration, then the diagnosis of systemic sclerosis is leading. Then sclerodactyly, if one has skin thickening over the fingers, if one has telangiectasias over the palms, over the cheeks, over the lips or tongues, then also you should think of systemic sclerosis. Calcinosis is nothing but soft tissue calcification, which is again a very characteristic feature of systemic sclerosis and dermatomyositis. NSIP pattern of ILD or pulmonary artery hypertension are quite frequently seen in systemic sclerosis. Now Raynaud's, I have told you, is pretty frequent, but if Raynaud's, if it is severe enough to cause digital ischemic ulceration, which is because of the small arterial disease, you should start thinking systemic sclerosis. At times they can have digital gangrene because of the involvement of the larger vessels, and because of the skin thickening, these patients can develop traumatic ulceration at the PIP joints. This is one of the patients I had who had this kind of white substance exuding out from the finger. So this is calcium deposit. So this is calcinosis. And if you look at the X-ray, so it looks very ornamental, but these are all actually calcium deposits in this patient. So this is again very much suggestive of systemic sclerosis. Now they can have skin thickening. There is a marked thickening of the fingers, and because of the perioral thickening, these patients have difficulty opening mouth. So again, if somebody is not able to open mouth, we have very few causes. One of them is this systemic sclerosis. Another one, if somebody has involvement of the temporomandibular joint, TMJ arthritis, or if somebody has TMJ dislocation, or in gutka chewer, they can have submucous fibrosis or tetanus. So these are very few conditions where we can have this decreased mouth opening. Then this is the another patient where you can see there is a marked skin thickening involving the trunk. Then they can have salt and pepper pigmentation. Again, this is very classical of systemic sclerosis because of the retention of the melanin in the perifollicular area. So they can have such kind of salt and pepper pigmentation. And these are the malar telangiectasias I was talking about. So apart from the cheeks, they can also have these telangiectasias over the palms, lips and tongue. And this is watermelon stomach, what we call as. So just like watermelon, these patients can have this gastric antral vascular ectasia, and in again NSIP pattern of ILD. Now moving on to the next connective tissue disease, which is the autoimmune myositis. So a young female presenting with subacute proximal muscle weakness developing over weeks to months. Again, you should start thinking inflammatory myositis. They can have concomitant dysphagia, they can have neck flexor weakness, and the classical rashes of dermatomyositis, calcinosis and ILD. Particularly if there is a overlap of NSIP and OP pattern of ILD, we should suspect myositis. So this is the Gottran's rash which you can see in this patient. So there is a macular erythema involving the fingers, and this is the holster sign. So holster is basically a leather case which is used to keep the gun, and it is tied to the belt. So this is the holster area. It is over the lateral aspect of the thigh. So this patient has both of these rashes, again seen in patients with autoimmune myositis. The other rashes which can be seen in dermatomyositis are the Gottran's papules. So these are erythematous violaceous papules present over the knuckles, over the PIP joints, over the DIP joints. At times they are not papules, but there is a flat erythema, there is a macular erythema which can occur over these areas as well as other extensor surfaces of elbows, knees and ankles, which is called as Gottran sign as depicted in image B. And in C image, you can see that there is a photosensitive rash over the anterior V of neck, which is called as V sign. And this rash can also be distributed over the nape of the neck, over the shoulders and the upper back, and this is called as shawl sign. And there could be periangual telangiectasias, capillary dilation, hemorrhages, cuticular overgrowth. So those are the other findings which can be seen in patient with dermatomyositis. Now if you look at both the images, they looks very similar, but what is important is that in dermatomyositis, this erythema is located over the joints. It is over the knuckles, over the PIP joints, over the DIP joints. Vis-a-vis in systemic lupus erythematosus, it is in the interphalangeal area. It is sparing the joints. It is not over the knuckles, it is not over the PIP joints, it is not over the DIP joints. So this is the difference between the rash in dermatomyositis and SLD. Now at times these patients can have these ulcerative skin lesions. They can have this erythema over the palmar aspect of this thing. And this is a very sinister sign. We should always be on watch out for this, because these patients can have rapidly progressive ILD. They can develop respiratory failure within 2-3 months, and it is associated with high mortality. Again, calcinosis, again a patient who had this kind of calcium deposits all over the body and very much similar looking X-ray, and they can have this is all white looking as the calcium deposit. So extensive calcinosis again is a feature of dermatomyositis apart from scleroderma, particularly in childhood onset dermatomyositis. Now another entity which is quite, I would say it's not very old entity, anti-synthetase syndrome. So this condition should be considered if a patient has complex of fever, interstitial lung disease, myositis, arthritis and Raynaud's. But what is mandatory is the presence of amino-acyl tRNA synthetase antibodies, most common being anti-Joban antibody. And this is again a very classical finding seen in patients with anti-synthetase syndrome. They have such kind of cracking or fissuring of the fingers, particularly over the particularly over the radial aspect of the index finger, and if such rash appears on the feet, then it is called as the hiker's feet. Now, when should we start thinking of overlap connective tissue disease rather than plain SLE? If a patient of SLE has myositis, if a patient has pulmonary artery hypertension, ILD, severe Raynaud's, puffy fingers, or erosive arthritis. So presence of any of these in a patient of SLE should make us think of overlap CTD rather than SLE. So this is what is shown in this image is the puffy fingers, which is a very classical feature of mixed connective tissue disease. Now, mixed connective tissue disease, as the name suggests, is a mixture of different connective tissue diseases, be it lupus, systemic sclerosis, rheumatoid arthritis, dermatomyositis, or polymyositis. But again, to make a diagnosis of MCTD, serology is important. We need high titer anti-U1 RNP positivity to label one as MCTD. If you look at the different criteria of MCTD, what is common to all the criteria is that serology is must. Serology must be positive to label a case as MCTD. Now, what is undifferentiated connective tissue disease? If a patient has some features of lupus or scleroderma or myositis or Sjogren, but it is not fulfilling the classification criteria of any of these. Say a patient has arthritis and ANA positive, I will call it as UCTD. Say as somebody has Raynaud's with ANA positivity, I'll call it as a UCDT because it is not fulfilling criteria of any of the connective tissue diseases. So what is UCTD? Again, they can have symptoms of either of these, but do not meet the classification or diagnostic criteria for any of the condition. Now going to the investigations, if you have suspected connective tissue disease in a patient, each investigation is of paramount importance. If somebody has cytopenias, say anemia, leukopenia, thrombocytopenia, you should think of SLE or Sjogren's disease. If inflammatory markers are raised, you should think of inflammatory myositis. If LFTs are deranged, if OTPT is increased, you should think of hemolysis, myopathy, or autoimmune hepatitis. If there is a hypokalemia, you should think of Sjogren's disease. Proteinuria is seen in SLE, Sjogren's, and MCTD. CPK muscle enzymes are raised in myopathy. LDH could be raised either in hemolysis or myopathy. Coombs test is positive in SLE. Complements are low in SLE and Sjogren's disease. Cardiac biomarkers are raised, which is because of the myocarditis is seen in SLE, MCTD, and myositis. Effusions on X-ray or ultrasound. So evidence of serositis is seen in SLE, Sjogren's, and MCTD. Erosions on X-ray are seen in MCTD and scleroderma. Calcinosis is seen in scleroderma and myositis. Acroosteolysis, the pulp loss and the resorption of the distal phalanx is seen in scleroderma. ILD changes are seen in Sjogren's, scleroderma, myositis, and MCTD. pH is seen in scleroderma, MCTD, and antiphospholipid syndrome, and myocarditis again is seen in SLE, myositis, and MCTD. Now this is the last slide. If we have suspected connective tissue disease, the go-to test is ANA, that is the most specific test. So if ANA is positive in a patient and patient has predominant skin and joint involvement, you can go for the ANA profile, and depending upon which antibody is positive, you can label it. If dsDNA is positive, Smith is positive, it's likely a case of SLE. If there is a history of relevant drug exposure and antihistone antibody is positive, you should think of drug-induced lupus. If somebody has amalgam of Raynaud's, sclerodactyly, myositis, telangiectasias, ILD, and the scleroderma specific antibodies are positive, we'll call it as systemic sclerosis. If high titer U1 RNP is positive, we'll call it as mixed connective tissue disease. If anti-amino acyl tRNA synthetase antibodies are positive, we'll call it as inflammatory myositis. And if there is a persistent Sicca symptoms and ROLA antibodies are positive, we'll call it as Sjogren's disease. Thank you.